Bismillahirrahmanirrahim. My name is Dr. Ziaul Haq, and I'm Assistant Professor of Pulmonology at Gaju Khan Medical College, Sawabi. Today we will discuss first topic of pulmonology in final year, which is pleural diseases. We have discussed these topics in fourth year, which were enumerate symptoms of chest diseases, interpretation of pulmonary function test, acute respiratory distress syndrome, asthma and COPD, pulmonary tuberculosis, and bronchiectasis. We have discussed these topics. If anyone has any issue or any question, he or she can ask me. We will discuss them. Learning objectives of this presentation. At the end of this presentation, the final year students should be able to describe pleural space, enumerate diseases of pleural space, discuss pathophysiology of pleural effusion, discuss signs and symptoms of pleural effusion, discuss investigations used for pleural diseases, differentiate between transudative and exudative pleural effusion, discuss management of pleural diseases, and answer the relevant questions at the end. Okay. Pleura and pleural space. The normal pleura is a thin translucent membrane consisting of one mesothelium and two thin layers of subendothelial connective tissue rich in lymphatics, arteries, vein, and nerves. Space between visceral and parietal pleura is called pleural space. And the function of pleura is to make space for movement, and it is a protective space in case of volume overload. If volume overloaded or intravascular volume increases, so it will go to the pleural or peritoneal space and prevent the organ from failure, like heart failure, kidney failure. This image shows this is the lung and this is the chest wall. Lung is covered by the visceral pleura, and the inner side of the chest wall is covered by the parietal pleura. The space between these two pleura is called pleural space. Normally, in fully expanded lung, the pleural space will not be visible. This image is of pleuroscopy. This is the inner side of the chest wall, which is covered by the parietal pleura, and this is the deflated or collapsed lung. So this space is called pleural space, which is at the moment filled by the air. These are the types of pleural diseases, which is pleural effusion. When fluid comes in pleural space, that is called pleural effusion. When blood comes in pleural space, that is hemothorax. And when pus comes to the pleural space, that is pyothorax or empyema. Pus in the pleural space is called empyema. When chyle comes due to any reason in the pleural space, that is called chylothorax. If blood and air both comes in pleural space, that is hydropneumothorax. In pneumothorax, when the air comes in the pleural space. And malignancies are also present. For example, mesothelioma, which is quite common here at Swabi due to the mesothelioma belt, which is due to the asbestos exposure in the environment, and meds to the pleura. So now we will discuss the pathophysiology of transudate pleural effusion. This is because of two reasons. Either the hydrostatic pressure increases or the oncotic pressure decreases. When it occurs, then fluid will not remain in the intravascular space, and it will goes out to the interstitial space and then to the pleural space as well, and will form pleural effusion. While in exudative effusion, any incident leading to the damage to the vascular endothelium or to the tissue of the pleura, it starts the inflammatory reaction leading to the vasodilatation of the capillaries in that area. So the capillary permeability increases and fluid will come out because of the leak of the plasma protein. So the oncotic pressure will decreases and fluid will go to the interstitial space and effusion will form. So what will be the symptoms of pleural diseases? Pleural diseases can present with the chest pain, like acute and onset. So that will be sudden acute and onset, that will be pneumothorax, or gradual in onset, then you can think of pleural effusion. Similarly, patient can present with cough, difficulty in breathing. If effusion or pneumothorax are small, then this dyspnea will not be that much significant. And if effusions are more in size, large sizes or pneumothorax, larger pneumothorax, then patient will be complaining of difficulty in breathing. And also systemic features may be there, like fever, sweating, weight loss. Signs of pleural diseases: there may be tachypnea or tachycardia, or there may be lymph node enlargement in case of malignancy, and you may see cyanosis if the patient has large pleural effusion or pneumothorax, especially tension pneumothorax. So the patient can have cyanosis, and rarely clubbing can be present. In respiratory science, we have inspection, palpation, percussion, and auscultation. On inspection, there will be reduced chest movement and expansion on effusion site, or there may be tenderness if the patient have empyema or pus in the pleural space, and the patient have dull, stony dull, or hyper resonant percussion note. On auscultation, there will be pleural rub or decreased breath sounds. Okay, what will be our approach towards the pleural diseases? The detailed history is important, and then physical examination is also important to know the site of the pleural disease, on which side pleural disease is present, on right side or left side, and what is the extent of pleural disease. Is it small, mild, moderate, or severe? Or the patient have small problem or larger problem? Then the first and important investigation is just X-ray towards the diagnosis of pleural diseases. Then ultrasound chest to confirm the finding of chest X-ray. And in some cases, CT scan chest is advised, especially in malignant problems. When there is fluid, so the fluid aspiration, which is called thoracocentesis, is important, and fluid will be sent for routine examination. If diagnosis of pleural effusion is not made, then pleural biopsy is indicated, and sometime the pleuroscopy, which is medical thoracoscopy, is also done for the diagnosis. Here in radiology, if pleural effusion is more than 200 ml in the pleural space, so that can be pegged by chest X-ray, PA, posterior anterior view chest X-ray. And when the fluid is more than 75 ml, so lateral decubitus chest X-ray can peg pleural effusion. Below this, pleural effusion cannot be pegged by chest X-ray. Ultrasound chest can peg up to 10 ml of pleural effusion, which is more sensitive than chest X-ray. Also, ultrasound can be used to localize the site for thoracocentesis, and also sometime one can differentiate the pleural effusion into transudative and exudative on chest ultrasound. And also loculation and septation can be seen on ultrasound and pleural effusion. and CT scan is more sensitive than chest X-ray and ultrasound. This is a chest X-ray of pleural effusion, which shows homogeneous opacification of the left lower zone, which is blunting the left CP and cardophrenic angle and making the meniscus sign. This is the meniscus sign, which is the a sign for the pleural effusion. Fluid of which is the sign of fluid present in the pleural space. This is another chest X-ray of pleural effusion. Here, we can say that this effusion is mesopleural effusion because half of the hemithorax is filled, more than half of the hemithorax is filled with fluid. And you can interpret this X-ray as homogeneous opacification of the right. Okay, this is homogeneous opacification of the right mid and lower zone, and also some part of the upper zone with a meniscus sign. So this is meso right-sided pleural effusion. When you see X-ray like this and the previous one, then one should do chest ultrasound. On ultrasound chest, here, this is the ultrasound. On X-ray, effusion will be white. On ultrasound, effusion will be black. So this is the liver, this is the diaphragm, and above diaphragm, this is mesopleural effusion. Here you can see the lung. This is the lung, and this is the chest wall. This is the pleural effusion, which is black. We can differentiate transudato and exudato pleural effusion also on ultrasound chest. If there are particles, whitish particles movable in this fluid area, then we can say that this might be exudative pleural effusion. Okay, so when we confirm then that this is pleural effusion, then next step is to do thoracocentesis, means aspiration of the pleural fluid, which is of two types. One is diagnostic and the other is therapeutic. If we aspirate 5-10 ml or up to 20 ml of pleural fluid with the intent of diagnosis, that we will send this fluid for routine examination or cytology to make diagnosis. This is called diagnostic pleural effusion. And when the patient has difficulty in breathing and we want to aspirate the fluid in order to relieve patient difficulty of breathing, so this is called therapeutic thoracocentesis. So this is the position for thoracocentesis. And here, this is the procedure how we do thoracocentesis, we localize the space from where we want to do pleural fluid aspiration. Local anesthesia given to the skin, then to subcutaneous tissue, and then to the down, and then to the parietal pleura, and also to the lower rib, upper border of the lower rib. First, we anesthetize the area, then needle should be introduced to the pleural space just above the upper border of the lower rib, because we don't want to damage the neurovascular bundle which is present at the lower border of the upper rib. When we aspirate the fluid, by looking at the color of the fluid, one can diagnose the type of the pleural effusion. Either this will be transudative or exudative. If the color is hemorrhagic, so this is hemothorax, and this will be exudative pleural effusion. And if the fluid is pus, so this is empyema, this is exudative. If the color is straw color, so this is exudative. If the color is clear fluid, clear water-like, so this is transudative pleural effusion. And when you cannot differentiate this on the basis of color, obviously you will send this for routine examination. So multiple tests done on RE to differentiate the pleural effusion into transudate or exudate. One is the density. If the density is low, so this is transudate. If density is more, this is exudate. And one is Revolta test, which is done on the bedside. Distilled water. In this test, distilled water taken in a tube, and few drops of acetic acid added to the distilled water in the test tube, and after that, one drop of pleural fluid added to the this tube. If precipitous forms, this is exudate, and if the pleural fluid mixes with the distilled water, this is transudate. So this is Revolta test. If protein is less, this is transudate 30 gram per liter, or if this is more than 30 gram, then this is exudate. Similarly, the LDH pleural fluid, LDH serum LDH ratio, and pH is also important. So if the fluid is transudate, clear fluid, then we will look into the systemic causes like dil, jigar, gurda, heart failure, kidney failure, or liver failure, or hypoalbuminemia will be the causes. So the diagnostic possibilities will be less, and treatment option will be the treatment of the causes of transudate. And if there is exudate, so there will be huge differential diagnosis, and there will be the multiple option therapeutic options. Sometime if patient has received diuretics, so the pleural fluid, protein, and LDH glucose ratio will be disturbed. So in that case, if we cannot differentiate the pleural fluid into transudate or exudate straight away, then we can apply Light's criteria. This is Light's criteria. Causes of transudates are congestive heart failure, chronic liver disease, renal failure, anemia. And anemia, there will be high cardiac output failure and hypoproteinemia, myxedema, and grass ascites. These are the causes of transudate. And causes of exudates, which is pneumonia and parapneumonic effusion, tuberculosis, carcinoma, pulmonary embolism. Pulmonary embolism can cause both exudate and transudate to pleural effusion. And trauma, because in trauma will be hemothorax, blood. So that is exudate to pleural effusion. And post surgery, there will be exudate to pleural effusion, and also inflammatory and connective tissue diseases. There will be like RA, rheumatoid arthritis, and SLE. There will be exudate to pleural effusion. So, what is the management of pleural effusion? Management is the treatment of the cause of pleural effusion. If pleural effusion is because of tuberculosis, then start anti-tuberculous treatment. And pleural effusion is less in quantity and patient is not dyspneic, then aspiration is not required. And when there is a mesopleural effusion, then anti-tuberculous treatment along with aspiration of the pleural fluid is recommended. And parapneumonic effusion, because there will be polymorphic pleural effusion and exudative, then aspiration of the effusion is recommended, even if that is less in quantity. Also empirical antibiotic therapy. And if there is septation in the effusion, then fibrinolytics like tissue plasminogen activator TPA or streptokinase are given through the chest tube. Or sometime if there are trapped lung, then surgery is indicated for this pleural effusion. And malignant pleural effusion, when pleural effusion comes in malignancy, then that is stage 4 malignancy. So the treatment is palliative. In that case, chest tube pass and pleural fluid should be drained and pleurodesis should be done. Pleurodesis is a procedure of creating inflammation in the pleural in parietal and visceral pleura to obliterate the space and adhesion of the pleura, both pleurae. Okay. So, in the remaining pleural effusion, treatment of the underlying cause is recommended. So when there is pus in the pleural space, empyema management, tube thoracostomy should be done, just intubation, and empiric antibiotic should be given to the patient. If there are septation, then thrombolytics given to break the laculation and septation. If the lung drape doesn't expand, then decortication. Decortication is a procedure in which the laculation, septation, debris removed from the pleural space and the peel formed on the visceral pleura should be removed. If empyema untreated, then it can go into the empyema necessitans or bronchopleural fistula and may go to the sepsis. Like we have discussed, the treatment of malignant pleural effusion is the palliation, mainly palliative treatment, in which chest tube pass into the pleural space and talc slurry or talc porridge given through the chest tube, and other to create inflammation in visceral and parietal pleura. This procedure is called pleurodesis, and sometimes pleuroperitoneal shunt made for especially for chylothorax. In chylothorax, if there is turbid milky exudates, that is due to the mainly due to trauma, surgery, or mm, tumor. Chylothorax is defined as when the fluid triglyceride level more than 110, then that is called chylothorax. Management of chylothorax is if the patient is not symptomatic and the effusion is low, chyle is low in the pleural space, then conservative management. And if patient is symptomatic, then chyle should be therapeutically aspirated, tape should be done. And if we do continuous drainage of the chyle, so chyle is rich in protein, the patient may be malnourished. So in that case, one should do proper surgery, which is repair of the thoracic duct, or radiation should be given to the tumor to stop the chyle formation. Despite of so many efforts, investigation, 15% of 15 to 30% of pleural effusion is unknown due to unknown causes. So when one one cannot diagnose pleural effusion on these pleural fluid RE cytology, then another step is to do thoracoscopic biopsy, which is called pleuroscopy, and it has a high yield for cancer and TB. Now we will discuss the pneumothorax, which is the entry of air into the pleural space, which can be through the lung or through the chest wall, maybe due to damage or trauma or due to lung diseases. इसमें सिम्टम जो है वो डिपेंड करते हैं साइज ऑफ द प्लूरल एफ्यूजन pneumothorax. If pneumothorax size is increased, then patient will be symptomatic. These are the X-ray of pleural effusion. Here you can see the hyperlucencies on right side. This is the hyperlucency on right side with the collapsed lung and absent lung marking in these hyperlucencies. You will compare this side with this side. So this is the lung, this is the ear, okay, and on this side there are lung markings. Here again, this is right side pleural effusion, in which this is the lung border, this is the collapsed lung, these are the hyperlucencies, and all upper, middle, and lower zones with absent lung marking suggestive of right side pneumothorax. Now we will discuss the tension pneumothorax, and it is a true medical emergency. So when the air escapes into the pleura, causing buildup of positive pressure in the thoracic cavity, may occur when patient on mechanical ventilation with air buildup, causing compromise of venous return and shock, and patient need immediate decompression. This is the X-ray, X-ray of tension pneumothorax. Here on right side, there is hyperlucencies with absent lung marking in the shift of the mediastinum, the heart mediastinum toward the left side. Here the venous return to the heart to superior and inferior vena cava will be compromised, and the cardiac output, if the preload not coming to the heart, blood is not coming to the heart, so there will not be too much output, and there will be low BP and shock. So now we will discuss the causes of pneumothorax, which are the maybe primary. In primary pneumothorax, the cause is unknown, and this is present usually in normal healthy individual. Sometimes in thin and tall individuals, primary pneumothorax are common. Secondary pneumothorax is when the lung is diseased because of the previous lung is damaged because of the previous disease, or the lung is compromised, like in TB or post-TB cases, in COPD, or in ARDS and asthma, chronic asthma. And pneumothorax can occur due to iatrogenic causes, like when we pass central lines, or during mechanical ventilation, or during lung biopsy. So this is the management of pneumothorax. We can divide this into primary and secondary. In primary pneumothorax, when patient is not symptomatic and the rim of air on chest X-ray is less than 2 centimeter, so no intervention required. Patient should be discharged, and ask the patient to come into the OPD within 2 to 4 weeks. And if the patient has difficulty in breathing and the rim of air is more than 2 centimeter, then aspiration is indicated. Aspiration we do air aspiration for pneumothorax and mid-clavicular line, second intercostal space mid-clavicular line, because this is the safest area. If patient improves with this aspiration, then he should be discharged, he or she should be discharged. If aspiration was not successful, then chest intubation should be done. And chest tube should be passed in safety triangle. Safety triangle is uh, formed by the present in the axilla and formed by the interior and posterior axial line. In the lower border is formed by a horizontal line at the nipple of the nipple. While in secondary pneumothorax, if patient is not short of breath and the rim of air is less than 2 centimeter, then and the size is between, okay, then just do observation for 24 hours and give high flow oxygen. And if the patient size was between 1 to 2 centimeter, then first do aspiration. If aspiration of air was successful by cannula or syringe, then observe for 24 hours and give oxygen. If that is failed, then do chest intubation. Okay, this is a X-ray of hydropneumothorax. This is an upper part there, in upper part of the X-ray. There is hyperlucencies with absent lung marking, and there is air fluid level below this level. This is the homogeneous opacification of the lower part. So this is fluid, this is level, this is air, this is hydropneumothorax. Okay, these are the cases you should answer this, read this, and then answer the following cases. This is a 25-year-old male presented to chest clinic with high-grade fever, cough for last 1 week. Also, he has right side chest, pleuritic chest pain, and difficulty in breathing for last 2 days. And he has used paracetamol. Examination पर टेम्परेचर 102 है, रेस्पिरेटरी रेट थोड़ा सा ज्यादा है, पल्स भी ज्यादा है. Chest examination showed reduced chest expansion on right side with localized tenderness and decreased air entry below angle of the scapula and stenoidal percussion note on same area. What is your diagnosis? So this is a empyema, pleural effusion, most probably empyema. इसके 2 differential diagnosis क्या हो सकते हैं? One is tuberculous pleural effusion और hemothorix. और अगर बहुत ज्यादा स्पेसिफिक आपने डिफरेंशियल लिखनी हो तो इसकी एक कंसोलिडेशन और मास लिखते हैं, मैलिग्नेंसी और प्लूरल टेक्निंग और मास, ये भी लिख सकते हैं. इंपॉर्टेंट टेस्ट कौन से कराएंगे? चेस्ट एक्सरे कराएंगे, अल्ट्रासाउंड चेस्ट एंड प्लूरल फ्लूइड आरई फॉर रूटीन एग्जामिनेशन. स्टेप्स ऑफ मैनेजमेंट क्या हो सकते हैं इसमें? एक तो सपोर्ट मैनेजमेंट, पेनकिलर, ऑक्सीजन पेनकिलर देना है आपने, दूसरा एंटीबायोटिक, और तीसरा ये बस आपने एस्पायरेट कराना है. केस 2 इसको रीड करें और साउंड को म्यूट करें, खुद आंसर करे, इस क्वेश्चन को देख ले पहले. अच्छा, इस पेशेंट की हिस्ट्री, एक तो शी इज फ्रॉम रिफ्यूजी कैंप, दूसरा ये है 2 मंथ से हिस्ट्री है, थर्ड शी इज यूज्ड एमोक्सिक्लेव एंड पैरासीटामोल सिफ्ट्राइक्सोन, एंड पेशेंट बहुत ज़्यादा टॉक्सिक भी नहीं है, प्लूरल इफ्यूजन है, यंग एज है, कोई मेलिग्नेंसी की उसमें साइंस इन्होंने नहीं दिए। सो व्हाट इज योर डायग्नोसिस? प्लूरल इफ्यूजन है, मोस्ट प्रोबेबली ट्यूबरकुलस प्लूरल इफ्यूजन है। ठीक है, तो इसकी डिफरेंशियल डायग्नोसिस एम्पाइमा और बैक्टीरियल प्लूरल इफ्यूजन हो सकती है, प्लूरल इफ्यूजन हो सकती है, और हीमोथोरिक्स और कंसोलिडेशन हो सकती हैं। दीज आर डिफरेंशियल। और 3 important steps for diagnosing: chest x-ray, ultrasound chest और pleural fluid, routine examination, बायोप्सी भी कर सकते हैं। दिस इज 4-1। और मैनेजमेंट का एस्पायरेट करना है फ्लूइड को, ईटीटी देनी है, और उसके साथ पेन किलर फीवर के लिए पैरासीटामोल। अच्छा, दिस इज केस नंबर 3, इसको भी म्यूट करें, आंसर दे दें। तो 65 ईयर मेल है, चेस्ट पेन और शॉर्टनेस ऑफ ब्रेथ के साथ आया है इमरजेंसी रूम में आफ्टर रोड ट्रैफिक एक्सीडेंट। तो प्लूरल एफ्यूजन तो है, लेकिन ये हीमोथोरिक्स की सिनेरियो है। लेकिन सिंगल एंड फर्स्ट स्टेप आपने एक्सरे कराना है, और 2 स्टेप्स ऑफ मैनेजमेंट में एक सपोर्ट मैनेजमेंट है, पेन किलर देना है पेशेंट को, एयरवे मेंटेन करना है, और ऑक्सीजन देना है, आईवी फ्लूइड्स देनी है। ठीक है, और चेस्ट इंटुबेशन करानी है ताकि हीमोथोरिक्स को आप ड्रेन कर सकें। दिस इज अनदर सिनेरियो, 30-year-old 10 tall male है, सडन ऑनसेट चेस्ट पेन है। सडन ऑनसेट जब भी आ जाए तो फिर आप निमोथोरिक्स को ध्यान में रखें, और इसकी रिड्यूस चेस्ट एक्सपेंशन भी है राइट साइड पर, एब्सेंट एयर एंट्री है, और हाइपर रेजोनेंट परकशन नोट है। सो देयर इज एयर इन द प्लूरल स्पेस। सो व्हाट इज योर डायग्नोसिस? निमोथोरिक्स, राइट साइड निमोथोरिक्स। एक्सरे कराकर यू विल कंफर्म, यू विल डू चेस्ट एक्सरे, 2 स्टेप में ऑक्सीजन दे और स्पायरेट कराएं, स्पायरेट और चेस्ट इंटुबेशन। थैंक यू।